share the screen. And that was the last question, or one of the last questions. Sorry, 57, 58. Okay, so the last three. Okay, so if you're working with a client who you believe would benefit from doing a step down exercise, you have them step down. They're leading with the left leg is the stance leg. Okay, so the very first thing you're going to do is you want to create the clinical picture, like what's actually happening. And sometimes the wording can be confusing. So make sure that you have a clear visual of the movement that's happening. And so in this case, you have the left leg, which is leading, which means that's open chain. So that's in the air. And the right leg is on the ground. And so that's the leg you're going to be analyzing. It could be analyzing, but it's the one that's going to be loaded. And then it says you're having them stand in a step and perform a step down. So that means they're going down. And that's the very next step. Is the very first thing you want to do is identify is the person's body mass of that moving segment, and not the whole body mass, but that moving segment, is it going down with gravity, or is it overcoming gravity, or is it not moving at all? Those are your only three options. It's either not moving, it's either descending, or it's ascending. And if it's ascending, it's concentric. If it's descending, it's most likely eccentric. And if it's not moving, it's isometric. So that's your very first thing that you're doing for that. With that said, then if you've already identified that, you can knock out anything that says concentric or it's not eccentric, in particular in this one, because you're going down. The next thing you want to do then is, after you identify the general, is the body segment moving most of the time, particularly if you're not talking about like a leg or an arm opposite, but if you're talking about torso and arm or torso and leg, all of the joints are moving in the same phase. That's most of the time. It doesn't necessarily mean that's the case. So like if you were doing something where you were doing a step down and then you were doing like shoulder flexion at the same time, so you were stepping down and lifting your arms above your head, your upper extremities would be moving concentrically and your lower extremity and torso would be moving eccentrically. So you generally can apply that, what the joint is doing. Like if you look at a squat, the hip, if you identified the whole segment of the lower extremity, the doing the same thing. And even in this motion here, if I'm doing like an overhead press, the shoulder, the elbow, and the wrist are all concentric in this phase, eccentric in that phase. So when you're talking about a particular segment, it generally applies. But if you're looking at different segments like the torso, the arms, and the legs, they might be doing different things. But for most part, if you're analyzing an exercise like an upper extremity or lower extremity, they'll be consistent. So once one joint's doing concentric, they're all doing concentric. But anyways, in this case, we have the eccentric aspect, and now you have to identify what the joint action is. And I would always try to start with the joint action instead of trying to figure out the muscles. Because once you get the joint action and you have the phase, then you can fill in the muscles. I never analyze a movement by its muscles. I always analyze by the joint and and I think that's how I kind of led you through this question 56, 57, 58, is I wanted you to start first with the identifying the phase of the movement and the actual joint, and then fill in the musculature. And in this case, in 56, you should have identified that the right knee is going through flexion because you're going down with gravity, not going up. And so your extension would be extension would be if you're climbing the stairs, but this is going down, you're flexing down, and it's going with gravity. So you should have picked flexion and eccentric at the knee. Then you go to the next question here, and it's asking you what muscles are involved in that. Muscles are, when you memorize muscles or when you look at the textbook, they're always listed, thus you're always learning them from their concentric action. So because you see knee flexion doesn't automatically mean that it's the knee flexors that are working. It's going to, even though you see knee flexion, that's the eccentric phase. The opposite of flexion is extension. And so the reason why I'm having you go through the opposites is that if you're trying to, it's going to be the opposite muscles that are at play, because those are the ones that are slowing you down. And so in this case, when you're controlling yourself down, it is the knee extensors that are working eccentrically. And so that's going to be the vastus medialis and the rectus femoris. Biceps femoris is a knee flexor, and iliopsoas is a hip flexor. You don't need to be accelerated in hip inflection here. You need to be slowed down. And so you need an opposite force. So it would be it would have been glute max or any kind of hip extensor, knee extensor, ankle extensor would be the opposing muscle. And I think the leap there that you need to realize is that muscles are named or learned for their concentric action. Like when you learn the knee extensors, you're learning knee extension for its concentric action, which is the quadriceps and the rectus femoris. But these muscles are involved in eccentric knee flexion. So hopefully that makes sense. And then when we come down to this one, it wants to know what's going on at the right hip. So right hip, what you're seeing is hip flexion. Wait a second, hold on a second. The right hip during the lowering phase. Oh, I see why it's wrong. Okay, I was almost getting confused myself here. That if I was looking at this quickly, I would have answered glute max and biceps femoris, right? Hip extensors. But it's not the right answer because it's not a concentric action, it's an eccentric action. And the sartorius is a hip flexor, not a hip extensor. So the sartorius would be involved in an eccentric hip extension activity. Or I'm sorry, I guess if the sartorius is a hip flexor, you would have been involved there, but it's knee flexion, eccentric. Well, this is a shitty question. The right answer would be sartorius, eccentric. Maybe. Yeah,
You said
if in my, I wrote, if I'm looking at this now, I would write this question different. I would not put a muscle here that is also a knee flex because it's actually not the appropriate knee muscle because sartorius is a knee flexor. So what I would have put here instead, it would be like maybe psoas or something that's isolated to a knee flexion. The problem with sartorius, it's a hip flexor. It's a weak hip flexor eccentrically or concentrically, and it's mostly looked upon as a knee flexor. And so that I would put the reason why this answer is here is to be a distractor to pick something with knee flexion, but it should have been that. So yeah, that would have been an arguable answer. So sorry, but it's a good learning aspect here. The right answer for this, if you were going to pick, would be glute max eccentric, biceps femoris eccentric. No, my whole thought process is wrong. What the hell? Okay, no, I'm right. I'm talking myself out of my right answer. Sartorius is not the right answer at all. It's a totally fine question. I fell for the trap that I was warning you guys for because I was looking so focused at the glute max and bicep femoris. Just because you see hip flexion going on doesn't mean that it's the hip flexors are involved. And in this case, the hip flexors are 100% totally off. So psoas is off, iliacus is off, rectus femoris, but it's working as an eccentric knee extensor, so it's working as a stabilizer. Sartorius is off, both at the hip and the knee. If you think about doing a single leg squat, and I'm coming down on one leg, I know you can't see it, but let's do this here, right? And I'm coming down on one leg, I don't need any acceleration bringing me down to the ground any faster. Although I'm doing hip flexion and knee flexion right now, the last thing I want are muscles that are going to pull me down and collapse me down. I'm trying to stay upright, and I've just broke the plane. Right here, I'm locked up. My bones are stacked on each other, so I have joint congruency. And once I break that plane, once I bend the knee and I bend the hip, now my extensors have to come on to keep me from collapsing. So that would be my knee extensors, my hip extensors, that these guys are working. They're slowing me down, although they don't necessarily produce hip flexion or knee flexion. They control hip flexion and knee flexion. So the right answer is stated there in none of the above. And the muscles that are involved at the hip, in this case, would be anything that's involved in extension. So sorry, I needed to get my brain wrapped around there for a second.
The hamstrings, would they just be doing an isometric?
Or that's the tricky thing. When you look at the sartor, not the sartor, when you look at any of the bi-articulate muscles, sartorius, rec fem, and the long-headed biceps, semitendinosus, they what they do is they kind of act like a belt-like stabilizer. Because what's happening is that, and it's not truly an isometric because they're shortening here and lengthening there. So that's the only odd thing with that. But they're working to produce a hip extension torque or moment.
Gotcha. Okay.
But is their length actually changing? No, it's not purely an isometric contraction, but that's a tangent, you guys. So don't freak like deep talk that anatomical nerds talk about. So, but look at it as a extensor, a hip extensor during that movement. Here's another way of looking at it. Isometric contractions and concentric contractions are basically the same when it comes to functional analysis, whether there's a movement or no movement, because there's some argument that isometric contractions don't really exist, right? Isometric shouldn't really be talked about in terms of muscle length change. It should be changed in terms about joint angle changes. And so in this case, when you're doing analysis, is that the hip joint is changing angle, and so there's definitely some change of length in the bicep. So okay, so stepwise function again. First, truly identify and visualize the movement. The next step is identify, is it going with gravity or against gravity, eccentric or concentric? The next step is identify the joints that are moving, flexion, extension, and just make sure you make a mental note that you're talking about joint motion only and not making any assumption on the muscle participation. Just because you see hip flexion, that doesn't necessarily mean the hip flexors are involved in that. Just because you see elbow extension or elbow internal, elbow doesn't, if you see shoulder internal rotation, that doesn't mean that the muscles of internal rotation are involved. If it's a concentric activity, then yes, the muscles are involved. If it's an eccentric activity, it's the opposite muscles that are involved. And if you want to make that as a mental note to memorize, eccentric, opposite, concentric, same, that's fine too. So eccentric hip flexion is going to be the hip extensors. Concentric hip flexion is going to be the hip flexors. If you're looking at muscle participation, muscle contraction type, make sure you're clearly connecting concentric with eccentric. Any questions, even with my confusing brain fart there with the sartorius?
I was also confused with question number 13. It says the knee joint can extend to 180 degrees normally, although some individuals can extend slightly further.
Yeah.
Wait, is that true?
Yeah.
Okay.
It was, if you look at the I think we talked about it in one of the January Cuvado, where you have up to 5 degrees of extension, right? So it's normal up to 5 degrees, but it can. Hey, you guys got to be. Hey, Carmen, you guys can't yell. Gotta keep it down. Got Hot Wheel tracks all over the house, and they're going nuts. So, okay, yeah. So you can see here, you can see like there was some surgical intervention here for normal extension, and you can see that there's about 5 degrees. This happens both in the knee and in the elbow. And you got, some people, they lock out, they'll sometimes call it double jointedness. You got severe situations where, like, this is actually kind of more on the lane of severe. You can have really severe where you're getting issues like this. Am I sharing my screen?
No.
Oh, look, guys. I think that happened last week. I thought I was sharing my screen talking about January. So maybe there's some hoax here. I don't know. This is so that's a normal 0 degrees or 180 degrees of extension, and there you go beyond that.
So it can be either 0 or 180. It's the same thing, right?
Well,
because I was a little confused about that because I knew knee extension was 0,
I don't know, let me see.
Wait, 180.
It can extend to 180 degrees normally. Yeah, it should be 0 degrees, but yeah, in terms of angle, 0 and 180 are the same, but that's not nomenclature. If you ever see a true false question, you'll know you won't see a true false question on my test, but true false questions are usually copied and pasted from the publisher content. So yeah, if I wouldn't necessarily put that there. Questions here that are non-true false, these are questions that I wrote, so those are the ones that, but these, yeah, that's not 180 degrees, it should be 0 degrees. And some people can go a little further, but meaning that you have 180 degrees of yeah, so you go from 0, and it'd actually be like -5 that you would write in the nomenclature. The point is, from this, the takeaway isn't to know the angles, is that genu recurvatum exists, that there's a little bit of hyperextension that exists at the knee.
So would some of these questions be similar to the ones we're going to be having in the exam?
Yeah, like these guys here, where you're looking at different like analyzing movements, knowing some of the attachment sites, like we talked about, the pes anserine, Gertie's tubercle. Yes, the true false were more to be like just kind of a make sure you're like a study guide type aspect, but that's the whole point of this practice exam, was to give you a taste of some of the type of questions that you would and kind of have you mostly to work through the material.
I got tripped up with was, I don't know what number it is, but it says the rectus femoris is more powerful in extending the knee when the hip is in extension.
Okay.
I looked at it because I had selected flexion, and I was thinking of isolating the muscle in like a seated leg extension position as opposed to standing.
Okay.
Could you walk me through that?
So that's dealing with passive and active insufficiency. So looking at muscles are going to be strongest when they stay in mid-range. And if I flex my hip, I'm shortening the rectus femoris, because the that is not a good image of it. These are all bad images, but the rectus femoris crosses the knee and crosses the hip, and so it's a knee extensor hip flexor. So if I wanted to maximally shorten the rectus femoris, I would do knee flexion, hip flexion. So if you're doing knee extension, hip flexion. So if your exercise is knee extension, when you get to the top of that, from like, let's say the example that you use is a seated leg extension, you are already at 90 degrees flexed, and so the more hip flexion you have, the faster you go into a shortened position, the weaker you're going to be down here at the knee. So if I can lengthen up here, it's going to give me a larger range of motion to be stronger at here at the knee. So as I go from hip flex to neutral to even maybe extend it a little bit, but maybe just in that neutral position, that's going to be better. So if I do like instead of doing a seated leg extension, I did like a laying down of supine leg extension. Not that this is a real exercise; it's just more of a way of making you think through the activity.
Like a straight leg raise?
Straight leg raise would be okay. I mean, if you wanted to, yeah, but what's happening is you're maximally shortened at the knee, and so as you go into hip flexion, you would start to maximally shorten at the hip, and then you would start to become actively insufficient because the rectus femoris is going to be as short as it can. A better way to look at it too is that a way that would probably be asked as a question is, if you're actively insufficient at the rectus femoris, what muscle tissue would be passively insufficient? So if you're actively insufficient in the rectus femoris, what tissue would be passively insufficient? So think about the position you would get, what you just said, right? Active leg raise. So leg, let's do straight leg raise. You know what? I have a PowerPoint that I created for another class that has some. Let's do that. Okay, so if whatever's happening on one side of the axis, there's a consequence on the other side. It's the opposite, right? You have an agonist antagonist relationship. And so if I'm shortening on one side, I am lengthening on the other side. There's no way for you to influence one side of the axis without that having an effect on that side, right? So if this is the agonist, this is getting the go signal, this is getting the stop signal. Since this is getting the go signal, this is generating tension, this is going to be relaxing. As this is shortening, this is lengthening. As this is moving into active insufficiency, this is moving into passive insufficiency. As this shortens here, maximally shortens, this is what's happening on the opposite side of the axis is maximally lengthening. So whenever you get a situation where you're passively insufficient or actively insufficient, you're getting the opposite on the other side of the axis. So in the case of the rectus femoris, where I'm looking at straight leg raise, I'm here, I'm maximally extending at the knee and I'm maximally shortening at the hip. So I am putting the rectus femoris in an actively insufficient position. At the same time, on this side, the hamstrings are maximally lengthening. So they're in a passively insufficient position. Then the reason why this is important, and I guess we don't get too much in this class, but hopefully you get to it in your musculoskeletal, we get to it in the KIN 231, is that when you're looking at your interventions now, when you see someone that can't go into hip flexion any further, right? You have options. You can either intervene at the tight tissue, the tissue that is overly tight, that's passively insufficient, or you can direct your interventions at the agonist for the weak tissue, the stuff that's actively insufficient. So you can either do facilitation techniques or exercises to improve activation, and do techniques or exercises to improve lengthening. And this is looking at active versus passive insufficiency. And then again, appreciating that what's happening on one side of the axis is happening on the other side.
I had a question on question 30. In the context of the pelvic girdle motions, which of the following statements is true of right lateral pelvic rotation? I wasn't really sure if it was asking for a transverse rotation or if it was asking for like the frontal lateral tilt.
Yep. So again, there's a difference between pelvic rotation and lateral pelvic rotation, and there's three ways of looking at when you look at a pelvis. So when you're looking at the pelvis here, and I look at movements, this here, this pelvis tilt, right? This left hip, and I think we talked about this in the lab, that's why the terminology of a hip hike is your best aspect. Your textbook uses a pelvic tilt, so you have like anterior pelvic tilt, posterior pelvic tilt, which is pretty consistent.
Yeah.
And your book also uses a lateral tilt, so this would be a right lateral pelvic tilt or a left pelvic tilt. The textbook that I use for this class uses the term pelvic rotation. It's just one of the other terms that are there. But there you have pelvic rotation that occurs in the transverse plane, and then you have lateral pelvic rotation. So a right lateral pelvic rotation is the same as a right pelvic tilt. So it's just a terminology from the book. I didn't go through the questions and update them for this because it's just a practice exam, but it's just because it's a nomenclature that's used in that textbook. For your exam, I'm going to use the nomenclature that we talked about here for this textbook, which is pelvic tilt. And I probably won't even use if I use pelvic tilt, I'm going to qualify it with left hip hike, right hip hike, because I think that's the terminology that makes the most sense.
Okay. And right lateral pelvic rotation would be the right pelvis going inferiorly. Right?
Did you say inferior? Yes.
Inferior, yeah. Okay.
Yeah. Another one of your students sent me an email and wanted clarification on your classmates, one of my students, about the hamstrings acting as a tibia rotator, and I thought that was a good question, and I wanted to explain that because she said she wanted to know where it was at in your textbook, and I said it's not there, but you don't need the textbook. And remember what I said in knee extension, because you're at that locked position, you're not going to get a lot of tibia rotation. Most of your tibia rotation is going to be present in about 20 degrees of knee flexion or more, right? So, and that's usually when the knee needs to rotate, or you have that screw home mechanism where it locked, but you need to unlock the knee in order to get any type of rotation. But if you're looking at the posterior view, and we say the knee is bent. And if you look here, you can see the tibia, the medial condyle of the tibia, and then you can see the superior or proximal head of the fibula. And if the femur is coming towards the camera, and I run a cable from here straight back, right, and this is where the semitendinosus, semimembranosus is attaching. If that muscle contracts, can you appreciate how it's going to produce external tibia rotation? Because it's going to be pulling it's going to be pulling that back and doing external tibia rotation. I'm sorry. I have it reversed because I have it flipped around. That's going to be doing internal tibia rotation because the muscles here are going to be pulling this way. So the foot's going to be turning in. And then if I have the biceps femoris that's coming down and attaching to the fibular head on the lateral part of the tibia, and that contracts, it's going to pull it this way, and that's going to create external tibia rotation. So your semitendinosus, semimembranosus, because the semitendinosus is attaching, the semimembranosus is attaching here. And yes, I know the semitendinosus comes around and attaches to the pes anserine, but it's on the medial side of the tibia. So it's going to have that torque to produce internal tibia rotation, external tibia rotation. So that's just looking at the hamstrings as knee rotators.
And the quads would mainly just be there for aiding with the patella, like patellar tracking.
Yeah, because they're they come in attached down here, and the only one that's really going to have any type of are going to be those fibers that are more vertical. Anything on that side of the axis can be involved with it, but yeah, you can have quad imbalances. So let's see, this was a right leg. So your vastus lateralis is going to have a lateral pull on the patella, and your vastus medialis is going to have a medial pull. Any other questions from the practice exam?
I had a question about the Q angle. So
Okay.
the Q angle, at the knee, we have a normal genu-valgum.
Yeah, slight. Yep.
So if we increase the Q angle, would that increase the genu-valgum?
It would, and that's what. Well, it wouldn't. It may not change the valgum, but it might be at the hip, the coxa. But the let's So it could, if you here at the angle, you may not change the how close that is, but and that's what the Q angle is. The Q angle really isn't a measure of the genu-valgum. It's more of this the angle at which the femur presents. The genu-valgum is more looking at like general condition of how much of the knee that's there, how much are you bow-legged, or so yeah, the number does change, but you could have you can see that in each of these positions here that this is the tibia is perpendicular. You can see that the tibia leans in a little bit, tibia is out. You could have an increased Q angle without any change in the tibia relationship, and that's just going to increase the angle of the Q angle that's there. So you don't have to have this genu-valgum or genu-varus, which is more looking at is the distal end closer, so your knees touching. You can have changes at the hip without having. So this knee position here, this presentation where you have a normal, you can have greater Q angles, and you're using Q angles to measure that. But I don't think we're going to ask any questions that complex.
Okay.
Yeah, because the way that this image is presenting it is that you're with the increased Q angle, it's guaranteeing a genu-valgum, and that's not the case. Where this becomes important and where you're going to have it in your clinical practice is the varus that's happening. Let's look up varus knee. Okay, I'm sorry, not varus, pronation. Pronated knee. You're going to be dealing with. This is where the theory of the Q angle is kind of is what thought is that when you have this weakness that occurs that allows that valgus to occur, so you can have an increased Q angle, and as long as the muscles are strong enough to resist that, you're not going to let that knee dive in. And that's what you're really focusing on from a performance enhancement or injury prevention or post ACL is why weren't the extensors, external rotators, and abductors through the entire kinetic chain at the ankle, the knee, and the hip, why were they weak to allow that collapse to come in? So the valgus and varus are artifacts from a bygone era for looking at like positioning, but this concept of looking at pronation through the lower extremity kinetic chain, that's the thing that you will be trying to counteract or try to improve in terms of exercise or manual therapy. But this is what's happening when you have weakness through that. When your body can no longer succumb to overcome gravity, you're going to see ankle pronation or flattening of the foot. You're going to see this. Well, you're not going to see that here. Let's look at this. You're going to see the pronation, the tibia internal pronation, in and this whole collapsing of through pronation through that whole lower extremity.
And to help counter that genu-valgum, would that be a lot of like a hip abduction to do?
It could be if the weakness is at the hip. It could be from extension through the kinetic chain. It can be the external. It can be the extensors working as external rotators. Probably some intrinsic foot musculature allowing that pronation to occur. Not enough stability through there, and maybe some hip extension aspect through the glute, and then that can be tied into the pelvic positioning. And then that brings you up through the core. So the rabbit hole goes deep. Good image here, kind of show that. Yeah, that other image, I want to see where that was from because that was totally wrong. Yeah, this is totally wrong. That's not what happens mechanically.
Can you share your screen?
Oh, what the shit? I don't know if it keeps on knocking me out, but I was just going through all these images here. Yeah, if it's at any point my screen stops sharing, you let me know. So, did you guys see this image as I was talking about pronation? No, okay. Well, so here I am just like looking like a mad, crazy man talking, just ranting. So this is what's happening at the foot is this whole pronation aspect. This is what's happening with the Q angle. And I showed some of those aspects with the Q angle there. But when you have an increased Q angle, you could have a genu-valgum where the knee's being driven in, but you can have an increased Q angle and your knee can be totally neutral where you're perpendicular, your shin is still perpendicular. So this is what you'll be dealing with from a mechanical aspect of undoing this foot pronation, internal tibia rotation, adduction at the hip or the genu-valgum that's being created, but it's really a muscular weakness thing that's happening that's causing this collapse. And I was showing that this image is wrong. That's why you can't trust everything you find on. Right? It's external tibia rotation. But this is what you're counteracting, which is causing then that gapping here that would cause strain on the medial collateral ligament, and then the knee. Then you have the ACL tear, and then that medial meniscus aspect because of that force right here from that lack of control through the lower extremity. And then you can kind of see how that can, and I think I used this image in one of our lectures, how that can be transferred up. So is your pronation, is your knee valgum really coming from anything in the lower extremity, or can it be coming from above, from like a pelvic tilt? Or, so I said the rabbit hole goes deep in terms of where the issue is coming from. The question is, as a practitioner, can you identify it? All right, any other questions on the practice exam or the upcoming exam?
Upcoming exam is 50 questions.
Yeah. And I'll be available tonight at midnight or tomorrow morning, first thing. Same thing again with the Respondus and the lockdown browser and the Oculus. I will post, if I think I thought I did it already, all the answer keys for the lab stuff, so you can kind of go through there and use that to review if you need to. It's 1:45 right now, and we spent most of the time on the review. I think it was helpful for the exam. Are you guys even, is your brain even there? Because I know you guys had like 4 labs and practicals. You got everything jammed in. Is your brain even there for going through the new material, or do you just want to push everything till next week?
Next week?
I'm fine. It's this unit that we're in right now is, I mean, they're trying to milk TMJ. There's not much more you can do with it. I combine those two together, so if we can hold on the TMJ lab and move that with the head and neck for our next week, and it kind of, so we're okay with that.
Would we only have class on Monday? I mean, or Tuesday, not Friday, because of Thanksgiving?
Thanksgiving is Thursday. You guys got some major shopping you're planning on doing?
Yeah, no.
Okay.
No,
I'll plan on having now whether people are there or not, but I still want to kick the recording out, so I will. I still plan on doing a live session on Friday at 1.
We're not going to do any like TMJ stuff now. No new material, which is fine by me. Is there any like major concepts that you could spit off your head that you would hope that we have a good understanding and grasp on for this exam, other than what we've already discussed?
Let's do a practice example together, and then I think you will feel better. Here. Let me just pick up. Let me share my screen again. Let's just pick an exercise. Let's pick a move. Let's use this guy here. All right, so let me mark it up a little bit so it makes it a little bit more.
Yeah.
Okay. Okay, gravity's down, and we'll say that he's in a. Let's say this is in the descent here. Okay, so we're in the eccentric phase. What's happening at this left knee? So this is left, right. Yeah, let's do this. What phase of the lift is this in? So first of all, so let's say that the test question would be, What's happening at the, let's see, this is, I can't see his left or right. This is his left leg, right leg. Okay. What's happening at his left ankle and his right knee? So the answer is going to be like, you're going to look at what's the joint action and what muscle or muscle group, we'll say just muscle group, is involved in this. The first thing you're going to do is you're going to look at what phase of the lift is this in. Is it concentric, eccentric, or isometric? It says he's moving, so it's not isometric. And he's in a downward phase. Gravity is down, so he's going with gravity. 99% of the time, that's going to be eccentric, but it has to be a qualifier. If it ever says that he's moving faster than gravity or moving explosively or quickly, then that's going to be a accelerant. But just for practical purposes, it's going down with gravity, eccentric phase. So we know for a fact that everything in the lower extremity is most likely going to be eccentric. What we're not 100% sure is what's happening up here in the upper extremity, but that's not part of the question. So now we're going to look at the joint action that's happening at the hip, at the knee, and at the ankle. So at the hip, what's happening here?
Flexion.
That's getting closer, so that's hip flexion. What's happening at the knee? Knee flexion. And what's happening at the ankle? Ankle dorsiflexion. This is your standard triple extension, or in this case, going with the eccentric phase of flexion, flexion, flexion. Okay. Let's analyze the back. What's happening here at the ankle? Plantar flexion, flexion, and hip extension. So hip extension's happening there. When we say, okay, and let's just analyze the joint. So we said flexion, flexion, and dorsiflexion. We said extension, flexion, and plantar flexion. What muscles are involved at my first question was what's happening let's analyze each of them. What's happening at the hip? You see joint action of hip flexion. It's eccentric going with gravity. What muscles are under tension right now? Which ones are producing force? And the answer is the hip extensors, and they're working eccentrically. At this joint here, it's going to be knee flexion, right? That's what you see. That's always what you see is what you get all the time with the joint action. In terms of muscles, that's hip flexion, that's knee flexion happening eccentrically. It's the opposite muscle, so it's the knee extensors that are working to control that motion. They're the ones that are slowing that motion down. And same thing here, you're seeing ankle dorsiflexion, but I don't need any extra force to bring me up this way. Gravity is doing all the work on its own to bring me in that direction. So it's these muscles here that are slowing me down, and those are the ankle plantar flexors, so the gastroc soleus and the extrinsic toe muscles that are working eccentrically, so the plantar flexors. Let's look at this side now. What you see here is hip extension, but the hip extensors may not be generating any force. If you were going to feel anything there in this position here, because you're being driven into hip extension, it's probably the hip flexors that are under tension right now that are controlling that motion. Knee extensors here as well, and probably ankle dorsiflexors there that are doing that. But there's probably not a lot of movement going here. That's why I'm saying probably. But this is when you do this exercise, your focus is on this lead leg here, even though there is a little bit of force through there. But clearly hip flexors there, hip extensors there, knee extensors there. And now let me ask you this question. If I were to do this the opposite way and said, what muscles are being involved in this motion, this direction on the up phase, what's happening there, there, and there, you would have no problem identifying or saying that, yeah, those are the quads, that's the glute, and those are the gastro. It's ankle extension, knee extension, hip extension. What makes it difficult is when you're starting the analysis in the eccentric phase.
In the eccentric phase, for the left leg, the hip flexors would be off.
for the left leg, the hip flexors. So because, yeah. Because this is the motion. This is which way he's going. He doesn't need any help to be. He's got a 45-pound dumbbell that's pulling him down. He's got gravity pulling his body weight down. He doesn't need any help going down into hip flexion. What he does need is he needs the brakes put on so this knee doesn't jam into the ground and fracture or this knee blow out. He needs something. He needs a force that's going to counteract. Let me just use another color. He needs a force that's going to counteract all of the effects of gravity. And so it's not hip flexors, that's hip extensors. That's not knee flexors, that's knee extensors. What is happening at the elbow and the shoulder? What joint action do you see here?
Flexion.
Shoulder flexion because the arm came forward, right? What joint action do you see here at the elbow?
Flexion.
Flexion, right? Is there any movement here? Probably not. He's probably doing a goblet squat. So he's keeping that stable. That's an isometric contraction of what muscles?
Anterior delt, biceps.
So shoulder flexors and elbow flexors. When you're doing an analysis, you can look at isometric and concentric as the same. And so it's isometric, concentric as the same muscles that are producing. And because they're generating concentric force or muscle contraction of those of that joint action, and then the eccentric are the opposite guys. This one I want right there. Okay, all right, let's do this one. Okay, so this is a weird, let's look at the other, I saw another image that I thought was. All right, so let's say there's an up phase and down phase. Let's do the downward phase of this. So we're looking at when the her movement is down towards the floor, so gravity, she's going with gravity. Looks like she's moving slower than gravity, so this is an eccentric phase, at least for the lower extremity and the torso. And we look at back to blue. This is similar to the step down, right? We have the right leg posted to the ground and she's leading with the left leg. So this leg's open chain, this leg's closed chain because this foot's free to move. This one's fixed by friction to the platform here. What joint action do we see happening at the hip, at the knee, and at the ankle? And again, it's the same. It's hip flexion, knee flexion, and ankle dorsiflexion. But if the question was asking which muscles are involved, she doesn't need to be accelerant down into hip flexion. She's already moving. These joints are already getting closer together. She doesn't need to go further there, further there, further there. She needs to counteract the force of gravity pulling her down. So she needs to generate an upward force there, which would be hip extension. She needs to generate an upward force there, which would be knee extension, and then she needs to generate an upward force there, which would be ankle plantar flexion. So it would be the hip flexors. I'm sorry, the hip extensors working eccentrically here, the knee extensors working eccentrically here, and the ankle plantar flexors working eccentrically there. And then let's say that her arms were down by her side, and as she's coming up, she's going up in that position. It would be similar to the movement we saw before, but in this case, it would be concentric, shoulder flexion, and that would be the shoulder flexors that are working isometrically, or in that case, concentrically. Let me do another one. There is as much variety with the lower extremity. That's why I said if you can really identify that triple extension and know which muscles are involved, I'm trying to think of like a lower body. Oh, let's do this one. let's do this. Yeah, that's fine. Okay, so we're going to go from this position. Oh, come on. We're going to go from this position to this position. So we're moving from, this is our starting position. So we're starting there and we're ending in that position. Gravity is down, right? Gravity is always down, never any other direction of gravity. And the resistance is the weight of the legs. And so gravity is pulling down on the legs. What joint action is happening at the hip? So that's hip flexion. And that's going against gravity. So that is a concentric movement. Knee extension is happening here. It's knee extension. There's a little bit of flexion, but it's knee extension. But it doesn't matter. The muscles are the same. Even if you say it's a little bit of flexion, it's overcoming gravity. So that's the knee extensors. And so if we look at the muscles that are working here, this would be the hip flexors. We're not there yet, but we'll be there next unit. You're also getting a posterior pelvic tilt, and that is creating some lumbar flexion. And oh, we did do pelvis this unit. So you're doing a posterior pelvic tilt. And remember, posterior pelvic tilt can be tied to hip flexion here. And that's the hip flexors working concentrically. And then if I return my position, if I go from this position to this position, I reposition, I'm going with gravity. That's an eccentric movement. Although you see hip extension occurring, it's the same muscles that were used to do that movement. So it's the hip flexors working eccentrically here, hip flexors working concentrically there. Oh, you know what? Let's do this one. Okay, so we start with our butt on the floor and we lift it up. All right, so you started from here. What joint action happened here?
Hip extension.
That's hip extension. Probably some level of knee extension. You know, it's kind of hard to tell, but we're going to analyze here. And what joint action happened at the shoulders?
Extension.
Shoulder extension. Yeah. So you have shoulder extension, hip extension, and we'll say the knee is a wash. We won't analyze the knee here, but it actually did a little bit of knee extension as well, because when you were in this position here, when you were down, you were here, and so you went from a knee flex position to less of a knee flexion, even though you really didn't come out of it. So you went from like 120 degrees of knee flexion to 110 degrees of knee flexion, but we won't analyze that guy here. We saw hip extension. Is this with gravity or against gravity?
Against.
It's overcoming gravity, so that's a concentric phase. So I saw hip extension. Those are going to be the hip extensors working concentrically. It's also a pelvic neutral position lumbar extension, so it's going to be the whole posterior chain, and then the hamstrings working as well because they are acting as a hip extensor. So pretty straight. It seems kind of boring. It seems kind of boring now as we're going through it. It's kind of easy to do. Just got to be careful on what they're asking for in the questions. Is there a question someone trying to say as something? let's do this, a single leg stance. So someone was asking my type of question. I'm definitely questions on single leg stance, particularly what's happening at the pelvis, because I think that's an important aspect of, is this a good one here? That's a pretty good image. So the image is really grainy, but it has a, aha. Okay, so when you are in a single leg stance, and this happens during gait or happens during like exercise, you choose to pick one of your legs up off the ground. First of all, when you stand on one leg, you naturally shift your weight over so that your base of support, your center of gravity is within your foot, right? So you're going to see a little bit of anytime anyone stands up, right? Right now, I have both of my feet. Let's say these are my feet. You're seeing here. My center of mass is right where my I can't hold this thumb, but like my center of mass. Let's say these are the footprints. These are my feet, and then it makes the outline of my foot. My center of mass is like right there where my thumbs are coming together, and so I can equally keep my weight distributed on both legs. If I pick up one leg, I have to shift my weight over mass to be right over my base of support. So whenever you see anyone pick up their leg, you're naturally going to see a little bit of sway there. What you will see during dysfunction, if someone does a single leg stance, particularly if they put a little knee flexion in, is that you'll see a little bit of this opposite. So my body weight's going to shift to my left. I'm going to lean to my left to kind of maintain my balance. But if I have dysfunction or weakness here, I'm going to get this crazy shifting to the right, more so because the knee's diving in because I can't keep that weight that way. Okay. So what we're going to analyze is when you are single leg stance, you pick this leg up. This is the closed chain. This is the open chain. What muscles are involved to keep your pelvis stable? What needs to happen here? What's going to happen at the pelvis in terms of hip function? So we're looking at frontal plane motion. Let me get my arrow going. So what's preventing? So this is dysfunction here, right? I guess the answer is right there. Son of a bitch. But all right, sorry. But all right. There's two sets of muscles that are at play here. But can you appreciate this here? That as this hip drops down, this is a left lateral pelvic tilt or left lateral rotation or a right hip hike or a left hip drop. It's all the same. It's all the same shit. All this just different names for the same exact thing that's happening. Your textbook uses left lateral pelvic tilt. What muscle forces do I need to generate in order to keep that elevated? And so you're going to see the hip abductors on this side that are contracting. They're going to pull that down. They're going to try to, because you see, what you see here is hip adduction, right? You can see, there's my midline. See that angle got closer on that side. So it was hip adduction that's happening. When I look at my midline here, that angle is not changing, right? That's staying. Let's show you this image here. So this is the posterior view, and I pick up my right leg here. That's going to drop down this way. That's the same as me doing hip adduction. So it's going to be the opposite side hip abductors that are going to be coming on to maintain that pelvic neutral or that pelvic alignment, pelvic horizontal. So the adductors aren't working. The adductors are, you want the adductors off as much as possible. You want those abductors on. And you probably can get a little stability with the adductors on the opposite side. But good question.
You say in a test question, would you give us the option to select only the abductors, or would you give us the option to select abductors and glute med?
Well, are you talking about like glute max being involved in that as well, or like the rotation?
Yeah, would you give us multiple muscles to select, like in the right picture?
Yeah, there would be like a series of things that are there in terms of like some distractors that may not be.
Okay.
But it would probably be like adductors and like hamstring muscles or. But like if I put glute max there, absolutely. Even though glute max is a hip extensor, it's an abductor. So that's why I would never put a muscle that could be argued, because I was the type of students that always argued. So if it's arguable, then I'm not going to put it there. It's going to be clear that it's meant to be a distractor, and it's clearly a distractor, or it's clearly the answer. And if you guys haven't known me yet, I guess you haven't had much time, but if you know me by now, I have no problem throwing test questions out if I think they're shitty questions. If after I look at it and I realize that I guess that didn't make sense, or you guys come to me with that. So it's fun. It's a debate. So come to me, argue with me. I'm open. Does this make sense? I think I'm sorry that I grabbed the image that had this. I just got excited because it was showing the there and after. But when we look at a lot of these movements, understanding that as you're picking one leg up, you are gravity wants to take over and drop this leg down, and so you need a response to that. So you're going to look at your hip abductors, you're going to look at your lateral flexors on this side to maintain that stability. I think that's it. Playing the Trendelenburg with the pelvic hip drop. Any other questions? All right, so next week, Tuesday, we'll go over the exam, and then we'll continue in with the trunk and spine, probably more head and neck. We'll have Thanksgiving on Thursday, and then Friday I'll be here again. Whether you're here or not, none of these have been mandatory, but hopefully they've been beneficial. They'll all be recorded, and then we'll continue on. And we have I think, what do we have? 3 weeks left? 4 weeks left.